who has been leading the clinical meeting as we have come towards the end of it. So starting today's presentations, we'll start with the first, that's Catchy Flu by Dr. Krupa from Medicine Unit 3.
Good morning, everyone. Presenting on behalf of Medicine 3. Mrs. S, a 31-year-old lady, booked at Chad G3P1L1A1 at 30 plus 1 weeks of gestation, present with antenatal chip complaints of gestational diabetes and hypertension, presented with fever for 5 days, cough and cold for 5 days, breathlessness for 1 day. There is no history of any throat pain or vomiting, no history of any bleeding, PV, elevated blood pressure values, headache, blurring of vision, vomiting, abdominal pain, or decreased fetal movement. She was prior to this admitted at Chad and was being evaluated for pyelonephritis, and she was already on injection piperacillin tazobactam, and she had completed 6 doses. At admission to us, she was on day 2 of azithromycin and oseltamivir for her new onset cough, cold, and fever. Past history, she has a history of gestational diabetes, currently on metformin SR 750 mg BD. Known case of gestational hypertension, just on home BP monitoring. On examination, her heart rate was 102 per minute. She was afebrile at admission. Respiratory rate at 28 per minute with a saturation at admission of 87 with V's bilaterally, which improved to 96% on steroid nebs. BP at 110 by 60, and subsequently the respiratory rate dropped to 22 per minute. JVP was elevated. There was no pallor, icterus, cyanosis, clubbing, lymphadenopathy, or pedal edema. A fetal well-being ultrasound done in the casualty itself showed a single live intrauterine pregnancy, which was cephalic, FHR was present, placenta was anterior, and there was adequate LICA. Per speculum, there was no leakage. Nebulization, salbutamol was administered in the ED. A respiratory system showed right-sided minimal fine crepitations. Per abdomen, there was no suprapubic or renal angle tenderness. The gravid uterus was palpable. Severe systolic murmur in the left second intercostal space. So the differentials we had considered when the patient came to us was that of a lower respiratory tract infection, probable a viral influenza or atypical pneumonia. Second thing was probably a community-acquired bacterial pneumonia with a worsening type 1 respiratory failure. Since she was admitted in Chad already with a complaint of pyelonephritis, a pyelonephritis with ARDS was considered. Lastly, dengue or scrub with ARDS was also considered, since this was the dengue scrub season that was going on. Initial investigation showed an HB of 10.6 with a total count of 6,000. Differential showed a neutrophil of 84% with a normal platelet. pH was at 7.4 with a PCO2 of 48 and lactates at 9.4 and a PF ratio of 89. Bicarb was at 32. Sodium at 146 and potassium at 3.2. Creatinine at admission was within normal limits. Dengue scrub serologies, which were already sent from Chad, were negative. We had sent a throat swab for PCR, which showed a influenza virus A positive. This is her X-ray at admission. The first X-ray is her X-ray at admission. The second one is day 3 of admission. Chest X-ray showed bilateral infiltrates with worsening pneumonia. Course in the hospital, she was given broad spectrum antibiotic coverage along with oseltamivir and azithromycin for atypical cover. In view of worsening type 1 respiratory failure and tachypnea, she was shifted to ICU, intubated on the same day. Betamethasone was given for fetal maturity, but subsequently she had an IUD and she delivered normally. She was started on ECMO. Bronchoscopy was done while she was intubated, showed unhealthy inflamed mucosa from trachea involving both lungs with lots of purulent secretion. Subsequently, she had a superadded bacterial infection, sputum grew, Acinetobacter baumannii, blood due Pseudomonas. This is day 8 of admission, that is day 12 of admission. Day 13 of admission, her inotropic supports worsened and developed a multi-organ failure. She developed septic shock with purpura fulminans. And on day 13, she succumbed to her illness. This is not a very rare, fancy case. It's just to highlight pregnancy and influenza. In pregnancy, influenza has a very bad prognosis. So we looked at a couple of studies. This is something that was published in the ECOG journal. Influenza virus infection in pregnancy. It's a systematic review that looked at it, which showed influenza virus has a very poor prognosis when it comes to pregnancy with respect to both hospitalization and once hospitalization, maternal mortality and fetal mortality. So it's a 2B level evidence that maternal health and pregnancy outcomes are severely affected by influenza virus. This is an article published in Journal of Global Infectious Diseases by our OG team, which shows, so basically they looked at around 951 pregnant women. They divided them into 476 who had a viral infection along with 174 healthy people. Out of the 476 that were there, 174 were tested positive in the viral PCR that we had sent. In that arm, we had one stillbirth. In the arm where we did not, they had viral influenza-like symptoms, but without a positive test, we had one stillbirth with 4 missed abortions. Whereas in the arm which had only 174 healthy women with no symptoms of any influenza-like stillness, we did not have any stillbirth or abortion. Statistically speaking, according to our study done here, there was a significant number of preterm deliveries that were there requiring prolonged ICU stay for the baby, but they did not really see a significant difference with respect to stillbirths and small for gestation age babies. This is another meta-analysis that was done in China, which showed effect of influenza virus on pregnancy outcomes. They showed a significant effect of preterm births with no other significance with respect to stillbirths and small for gestation age. So based on these, the current ACOG recommendations are all adults should receive an annual influenza virus, including pregnant women should receive an inactivated influenza virus as soon as it is available to them at the first point of contact. So it is currently part of the recommendation, even as part of prenatal counseling, to start perinatally to start give a shot of influenza vaccine. Patients with influenza-like symptoms should be treated with antivirals. So the recommendation is either oseltamivir 75 mg BD for 5 days or OD for 10 days. There is also an indication to give a post-exposure viral chemoprophylaxis in patients who are pregnant or up to 2 weeks postpartum. This includes patients who've had pregnancy losses. So the learning point is influenza has a significant, unlike what we take it as a very routine thing for our adult regular population, has a significant maternal and mortality and morbidity. There are adverse fetal outcomes associated with influenza. There is a role for vaccination. Vaccination is currently part of the recommendation, and the treatment is still with oseltamivir, early treatment of oseltamivir, including our patient. The treatment started off a little late because patient came to us quite late. Early treatment with oseltamivir is still indicated. While we are talking about this, this is patient who is currently admitted with us in our ICU. She's an elderly primate at 30 plus 6 weeks with a DCD twin. She's tested positive for H1N1 virus. And this is her current X-ray as of yesterday. So influenza needs to be taken seriously when it comes to pregnancy, and it needs to be recognized and adequately managed.
Thank you, Krupa. Any questions? What is the mortality?
Yes. Yeah, thank you. Thank you very much for the presentation. Actually, when the patient came to you from Chad, your diagnosis was, you start your diagnosis or your clinical reasoning with the pathophysiological phenomenon that you're seeing. The pathophysiological phenomenon that you're seeing is a patient with hypoxia, tachycardia, 121 is the heart rate, as well as a respiratory rate of 22. So your differential diagnosis should begin from what is causing this type 1 respiratory failure, and you made it as a physiological state, ARDS. Query due to influenza viral, query due to bacterial, query due to, sepsis induced, query due to scrub typhus induced, because this patient is coming from the community. Now you've also made it that is a very good clinical diagnosis as such, but the fundamental clinical reasoning issue should begin with respiratory failure and what is causing it. Then you saw shadows in the lung, and then you made a diagnosis of bilateral bronchopneumonia or bilateral pneumonia. And you also said that there's a left-sided basal crepitations. Wonderful. So you might have said that it could have even been lobar pneumonia. But lobar pneumonia by itself will not produce such a significant hypoxia of oxygen saturation 50%. Having said so, and patient came from Chad and was not intubated in the ER, but was intubated in the ward and then shifted to the ICU. Question is, the degree of awareness of a patient going to be in shock or let's say respiratory failure, is something that one should look earlier. It's not that you could have saved the patient, but also please mention the temperature. Afebrile is different from a 98.4 or a 95 or a 97. What I am getting to is whether it is first trimester, second trimester, or third trimester, or a normal adult, the chances of survival is very low. And you went on to the highest level of providing care and treatment, ECMO. That's good, wonderful. You did your best to solve the problem. But what is concerning me also is how did she get Pseudomonas in the bloodstream? How did she get Acinetobacter from wherever you isolated it from the respiratory tract? It is from Chad, or is it from which other source? They are also adding to the potential of causing an ARDS-like syndrome. What are your thoughts on that? And which trimester do you think is the worst? First trimester, second trimester, or third trimester? Either way, in that chart, flow chart that you created, no? It's usually third trimester is easy. Third trimester is just like an adult male or an adult female getting. First and second trimesters are the more worrying period. As very nice presentation. Thank you. Just a thought. I'm just sharing my thoughts on this. Pseudomonas, how did you think it came in?
Pseudomonas probably she was in the ICU for a prolonged time. So these are cultures that grew subsequently after a prolonged ICU stay. So we still think it's a hospital-acquired infection and not from Chad or from the community.
Okay.
Thank you, Dr. Dilip, for your comments.
What was the susceptibility? What was the susceptibility? Pan susceptible?
No, sir, it was pan-resistant Pseudomonas that we had actually got.
Okay.
Thank you, Krupa, for your presentation. Thank you, sir, for your comments. Just one more thing is that what was the mortality among all these ladies that you presented?
So there are multiple studies which shows up to 12 to 15% is where the mortality is placed, but it depends, various studies done in various places. In our study that we've done here, we've not specifically looked at mortality. We've looked more at the fetal outcomes and maternal mortalities that we've looked at.
The second thing is, was there a commonality among the GDM and gestational hypertension determining the mortality and the outcomes? Was that looked into?
We specifically haven't, but GDM definitely could have, but her sugars actually with us were quite controlled when she had come to us. But GDM may have predisposed her to developing the infection in the first place and the morbidity course that was there.
So next question will come is, should all the pregnant ladies be vaccinated, or is there a high-risk group that we can identify to vaccinate? Because recommending vaccination at this point of time, what is the recommendation?
The current recommendation is actually to vaccinate all pregnant women at first point of contact.
So I guess, so those are some things that we have to keep it in mind, that are there any high-risk categories who definitely should be vaccinated, or bottom line, everyone should be vaccinated given the maternal and fetal outcomes that we have in mind? Something that triggers ourselves. Most probably we don't have very great statistics to really justify what we should do.